Hello everyone. In this lesson, let's study something about rapidly progressive glomerulonephritis, RPGN for short. Rapidly progressive glomerulonephritis includes glomerular disease that progress to renal failure in a matter of weeks and months. The renal biopsy in all rapidly progressive glomerulonephritis shows extensive extracapillary proliferation, that's crescent formation. Patients with primary rapidly progressive glomerulonephritis can be divided into three patterns as defined by immunologic pathogenesis. Those with anti-GBM disease, such as Goodpasture syndrome. Those with immune complex deposition, for example, SLE, post-streptococcal glomerulonephritis, and those without immune deposits or anti-GBM antibodies, so-called post-immune, usually ANCA positive. Anti-GBM disease is caused by circulating antibodies that are directed against the non-collagenous domain of the alpha-3 chain of type 4 collagen. These antibodies damage the GBM, thereby resulting in an inflammatory response, breaks in the GBM, and the formation of proliferative and crescentic glomerulonephritis. If the anti-GBM antibodies cross-react with and damage basement membrane of pulmonary capillaries, the patient develops pulmonary hemorrhage and hemoptysis, an association called Goodpasture syndrome. Clinical manifestations. Renal function may deteriorate from normal to dialysis, requiring labor in matter of days to weeks. Patients with pulmonary involvement may have life-threatening hemoptysis with dyspnea and with diffuse alveolar infiltrates on chest radiograph. The pathology of anti-GBM disease shows a proliferative glomerulonephritis, often with severe crescentic proliferation in bone space. There is linear deposition of immunoglobulin, usually IgG, along the GBM on immunofluorescence, but electron microscopy doesn't show electron-dense deposits. Treatment. Intensive immunosuppressive therapy with cyclophosphamide, for example, 2 mg per kilometer per day as tolerated, and corticosteroid, for example, plasmaprednisolone, 15 to 30 mg per kilometer to maximum of dose of 1,000 mg daily for 3 doses, followed by prednisone 1 mg per kilometer per day PO to a maximum to 60 to 80 mg per day and slowly tapered after achieving clinical remission to reduce the production of anti-GBM antibodies. Combined with daily plasmapheresis to remove circulating anti-GBM antibodies, rapid treatment is recommended to prevent irreversible renal damage. Is necessary in patients with pulmonary hemorrhage. Patients who already require dialysis at the time of treatment generally don't regain renal function despite aggressive therapy. Relapses of the disease are rare. Rapidly progressive glomerulonephritis associated immune complex mediated damage to the glomeruli can be seen with idiopathic glomerulopathies, such as IgA nephropathy and idiopathic membranous proliferative glomerulonephritis, or with systemic disease such as post-infectious glomerulonephritis and SLE. Post-immune rapidly progressive glomerulonephritis includes patients with and without evidence of systemic vasculitis. Most patients have circulating ANCAs that are directed against components of neutrophil primary granules. Clinical manifestations. Patients often present with progressive renal failure. Patients with microscopic polyangiitis often have circulating perinuclear ANCA, and with arthritis, dermoleukocytoclastic angiitis, pulmonary disease, and constitutional and systemic signs. Patients with granulomatous polyangiitis often have circulating cytoplasmic ANCA, upper and lower respiratory tract involvement by granulomatous angiitis, as well as post-immune glomerulonephritis. Both ANCA and anti-GBM bodies. Patients with eosinophilic polyangiitis usually has a history as asthma, pulmonary infiltrates, and circulating eosinophilia. For induction therapy, combination therapy with corticosteroids, for example, pulse-muscle prednisolone, 10 to 15 mg per kilogram per day, up to a maximum of 500 to 1,000 mg IV daily for 3 days, followed by prednisolone, 1 mg per kilogram per day PO, and cyclophosphamide, for example, 15 mg per kilometer IV every 2 to 3 weeks, or 1.5 to 2 mg per kilogram per day PO, with or without plasmapheresis. Rituximab, a monoclonal antibody against CD20 positive B cells, is as effective and safe as a cyclophosphamide at 6 and 18 months. Methotrexate is as effective as cyclophosphamide in achieving remission, but it leads to a higher relapse rate, so it is not an initial alternative to cyclophosphamide or rituximab in most patients. Okay, that's all. Thanks.